Professor Yalçıkaya, you can start.
Dear participants, I want to start my words by saying welcome to you all at the first Pediatric Nephrology Training Meeting of 2021. We will host a very important scientist, Giovanni Montini from Italy. I think you all know him, but I would like to briefly talk about his background. Professor Montini is a pediatric nephrologist. He is the holder of Giuliana and Bernardo Caprotti Chair in Pediatrics at the University of Milan, and is the director of Pediatric Nephrology, Dialysis and Transplant Unit of the Foundation Granda Research Institute in Milan. His main areas of clinical expertise include renal involvement in urinary tract infections, congenital abnormalities of the kidney and urinary tract, pediatric renal transplantation, acute and chronic renal failure, nephrotic syndrome, and renal involvement in mitochondrial diseases. Since 2010, he has been part of an international collaborative network project for pediatric nephrology set up in Nicaragua to help underprivileged children with kidney disease gain access to medical care, dialysis, and transplantation for impossible children with kidney disease. He took over the directorship of the project in 2018. He is an accomplished researcher and lecturer in the field of pediatric nephrology and has published over 200 articles. I would like to conclude my words here and invite Giovanni to present his lecture. Thank you.
Thank you, Fatosh. Thank you very much, August, and thank you also to Rezan and to all my Turkish friends. It's really a pleasure to be here with you and to speak about one of the topics I really like a lot. And can you see my screen now? Right? Good.
Yes,
Yes, we
we
can see.
can see.
Good. Basically, urinary reflux and urinary tract infections in children. This cartoon depicts the epidemiology of UTI in children. Red bars are girls and blue bars are boys. And this is a Dutch study done in general practice by 195 general practitioners with over 82,000 children aged up to 18 years old. The incidence in this cohort of children was over 19 UTIs per thousand per year. And as it is very clear from the bars, girls had much frequent UTI than boys. At time, the incidence of boys. And the incidence for girls is mainly during this part of the life and thereafter during adolescence. But in this cartoon, you can see that during the first 2 to 3 years of life, the number of UTIs are much lower. And this is perhaps, this study has been done in general practice, and there are no data for children who have been admitted to hospital. And generally, children at this time of life are frequently admitted to hospital because of a UTI. And on this case, we have data from the Swedish experience on the epidemiology of UTI. And we can see here are depicted girls on this part of the cartoon and boys, these are the other one. These are the febrile UTIs, and these are the non-febrile UTIs. Girls have febrile UTIs mainly during the first 2 years of life, and thereafter are mainly non-febrile UTIs, while boys have very rarely during that period UTIs, and they are mainly febrile UTIs during the first year of life. And these are data from one of our studies, and we can see on this study that the number of infections are more frequent in boys during the first 6 months of life. If we see the problem from the other point of view, and so we want to know how many children present to a pediatrician with fever, and how many of these children will have, as a cause of the fever, a UTI, we have this very interesting meta-analysis. This data show that 7% of children presenting with fever to pediatrician during the first 2 years of life and with no other apparent causes of fever, such as pneumonia or otitis, they will have as a cause of the fever a UTI. And there's a very clear distinction for boys during the first month of life. And the distinction relates to the circumcision state. If you are circumcised, 5% of the boys will have as a cause of the fever a UTI. If you are uncircumcised, 20% of the boys will have as a cause of the fever a UTI. Why does a UTI happen in a child? There are some risk factors related to the host, and these risk factors are related to the white race. White children have more frequently UTIs, younger children and older girls, familiarity, and there are some other non-modifiable risk factors. And among these risk factors, the presence of dilating reflux is very important as a risk factor for UTI. But there are also risk factors associated with the bacteria. And this is the very smart uropathogenic E. coli, which is the main pathogen of UTI in childhood. There are a number of factors which promote the virulence of bacteria. These factors includes machineries to catch specific nutrients such as ion acquisition systems like siderophores. And that's because ion is required for bacterial replication. UPEC strains can also produce and secrete toxins, which damage the urothelial cells of the host, disrupting integrity and providing the site of attachment and invasion. And the uropathogenic E. coli can also produce peeling and use multiple adhesins to bind proteins expressed on host bladder and kidney uroepithelial cells to trigger attachment and invasion and cause infection. And among those factors, very recently, a lot of attention has been given to human uromodulin filaments. You know very well that uromodulin is the most abundant protein in normal human urines. And it has a specific role because it antagonizes the adhesion of uropathogens. And they can be associated with the UTI, a reduced production of uromodulin, a reduced presence of uromodulin in the urine can produce a higher risk and a higher number of urinary tract infections. And that's quite interesting also in future perspectives, because uromodulin, like some other molecules, like epsilon, like defensin, like ribonucleases, has been defined as antimicrobial peptides. And more than 2,000 antimicrobial peptides has been identified. And more than 100 are human antimicrobial peptides. And some of these antimicrobial peptides have been now studied in specific infections and specific diseases. We hope that in the future, this can be used to treat some of these infections, such as for urinary tract infection. So what does happen when E. coli arrives to the kidney? It arrives to the kidney and triggers the innate immunity through TLR4 receptor, which produces a high quantity of NFK beta, which goes to the nucleus of the cell and triggers the production of cytokines and chemokines. And among those cytokines, there are some which are quite important because interleukin-6 produces the fever. And that's why pyelonephritis is usually associated with fever. Interleukin-2 triggers the recruitment of neutrophils at the kidney level. And TNF-alpha triggers the increased inflammation and permeability always at the kidney level. Usually, we have a clearance of the infection and of the inflammation, but in some children, there's a possibility to have a residual scar formation. And this is what has been worrying pediatricians, pediatric nephrologists, pediatric urologists for many years, because there was the feeling that a lot of kidney damage and some of the children who end up in end-stage kidney disease and need dialysis transplantation could be caused by scar formation. But we have reevaluated this possibility. And nowadays we know that most of the kidney damage important which produces end-stage kidney disease in our children is related to congenital kidney damage. And there are a number of data presented in the literature. These are data from the Italian registry of chronic kidney disease in children. And this is a cohort of 187 children who has been diagnosed with vesicourethral reflux and chronic renal failure. These children have been diagnosed mainly during the first year of life. And for males, which are the red lines here, 40% have been diagnosed at birth before of any infection. So chronic renal failure is secondary to a congenital kidney damage. And there are studies published in the literature, and this is a meta-analysis of many published studies and data, which have shown that in most studies who have evaluated long-term kidney function in children with urinary tract infections and vesicular reflux, most of the damage was congenital and was present at the beginning of the follow-up and often before the infection. So almost of children in this big meta-analysis of more than 3,000 recruited children in a number of prospective studies, almost of children with a decreased renal function at the end of the follow-up show scars or hypodysplastic kidneys at start. And this is another important study published very recently, where 260 women with UTIs in childhood were studied at the moment of pregnancy. And the group of control was a group of 500 women with no previous UTI in childhood. And what is quite interesting from this study is that the primary outcome, which was any pregnancy complication, was absolutely the same between the two groups, between the woman with previous UTIs and the woman without any UTI during childhood. So making very clear that there is no risk at pregnancy for these women. So from this side, my conclusion is that we have a big number of children, which is the green circle here, who have a febrile urinary tract infections. 20% of these children, we have a vesicular reflux associated with a UTI. But we know from a number of studies that there are children with vesicular reflux and no infections. 15% will have a post-infectious kidney scarring. And half of these children have a infectious kidney scarring in association with vesicular reflux, but there are also children who have a scarring without a vesicular reflux. And at the end, we have a small number of children who have a renal hypodysplasia, a vesicular reflux, and those are the children who really need our attention because those children have a reduced renal mass and are those who are at risk of developing kidney damage in the long term. Regarding urinary tract infections, we have recently updated our recommendations, Italian recommendations, for the diagnosis, treatment, and follow-up of the first febrile UTI in children. And I will very briefly summarize these recommendations regarding imaging. Our recommendation in children between 2 months and 3 years of age is that every child with a febrile UTI will need a renal ultrasound. If the ultrasound shows one of the abnormalities cited in the box here, with the presence of unilateral or bilateral renal hypoplasia, the presence of abnormal renal echogenicity, a pelvic calyceal dilatation, the presence of a ureteral dilatation, a thickening of the uroepithelial layer of the pelvis, or the presence of bladder abnormalities, or if the infection is due to a pathogen other than E. coli, they will deserve the study of the bladder for the presence of reflux. And the study of the bladder could be done with a VCUG or a radionuclide cystography or a cystography performed with ultrasound. In case a child will have a second febrile UTI, and he has not done the study of the bladder for vascular reflux because he didn't have any of the risk factors cited here. In case of a second febrile UTI, it would be important to the study of the blood. If we go to see what is written in the published guidelines for imaging following a first febrile UTI, and we see what is recommended for VCUG. It's quite interesting to see that all the guidelines made by pediatricians and physicians do not recommend the routine use of VCUG in a child following a febrile UTI. But most of the guidelines done by urologists and surgeons, they do recommend the performance of a VCUG. As regards the DMSA scan, most of the guidelines do not recommend a DMSA scan as routine. Just in some cases, such as the Italian guidelines, they would recommend to do a DMSA scan in case of presence of very abnormal ultrasound or a high-grade reflux. And because of this difference between the recommendations done by pediatricians and the recommendations done by surgery, we have looked at the literature and we have looked to the studies were published between 2011 and 2018. And we found 62 reviews and 83 studies where clear recommendations were made regarding investigation and on management of a first febrile UTI. It's quite interesting to see as a reduced imaging was recommended by the most part of the studies performed by physicians, but by a small part of studies performed by surgeons. Diagnosis of a UTI is quite important. How to perform a diagnosis? What we recommend now is a two-step approach to perform first a urinary dipstick, and if the urinary dipstick shows the presence of nitrite or leukocyte esterase, UTI is very likely and is necessary to perform a urine culture and start antibiotic empirically. If leukocytes are negative, the possibility to have a UTI is very unlikely, so we suggest to search for an alternative diagnosis. How to perform UTI for urine culture? UTI to perform urine culture should be performed in primary care through the use of clean voiding specimens of midstream urine. Bag is not recommended. The catheterization of the bladder should be the first choice in hospital settings. As regards the possibility to obtain a midstream urine sample in children, there are a number of studies quite interesting. This possibility is very easy to obtain within the first month of life. This is a study performed in 80 patients aged less than 30 days. And this technique, a very simple technique, tapping the suprapubic area, stimulating the lower back, it's obtain a midstream urine in 86% of infants in a median time of 45 seconds. This is not possible in older children. I mean, if you have an 18-month-old child, but up to 6, 7 months of age, it's quite possible to obtain. What we recommend as far as urine culture and cutoff is concerned, we have gone through the literature, and there are a lot of numbers and a lot of definition of a significant colony count depending on the collection method. And we ended up recommended to have a urinary colony forming unit higher than 10,000 for suprapubic aspiration and bladder catheterization, and higher than 50,000 for a midstream urine sample. What about vesico-urethral reflux, especially what about antibiotic prophylaxis and surgery? That's a very big chapter, with a lot of controversies and a lot of different opinions. But why should we look for a reflux? We should look for reflux because we need to treat reflux in order to prevent recurrence of febrile UTIs and to prevent the occurrence of renal damage in these patients. Have we been able to reduce febrile UTIs in these children and to reduce renal damage? Well, we have some interesting data, but first of all, I would like to make some simple statements on the reflux. And what I really like is this definition and this differentiation between two kinds of reflux. Reflux such as a disease and reflux such as a symptom. Reflux as a disease is mainly present in boys. It's diagnosed very early in newborn and infants. It has usually an antenatal presentation with a dilation at the prenatal ultrasonography. It's usually a high-grade reflux. Renal parenchyma is usually abnormal at the DMSA scan. It's a resolution rate of less than 50%, and it's very rare generally. Reflux as a symptom is mainly present in girls. It's a low-grade reflux with a normal renal parenchyma. Its presentation is generally secondary to urinary tract infections, has a very high grade of resolution, of spontaneous resolution, and is generally related to bladder dysfunction. So what do we have from the literature as regards the use of antibiotic prophylaxis in reflux? This is a meta-analysis which shows clearly that there is a positive effect of antibiotic prophylaxis in reducing the number of recurrences, of UTI recurrences in children with vesico-urethral reflux, both in dilating reflux and no dilating reflux. But this effect is mainly given by the REVO study, which really allows for the presence of a significant difference. If you remove the REVO trial, there's no significant difference, especially for no dilating reflux. So let's go to the REVO study, which is a quite important study, a very well done study by our USA colleagues, where they randomized more than 600 children for 2 years, half of them to receive antibiotic prophylaxis and half of them to receive a placebo. But if we see, 92% of these children were female, and 92% had low-grade reflux, grade 1, 2, 3. And almost all of these kidneys, 97%, were normal at renal DMSA scan. So this is mainly a reflux symptom. It's not a reflux disease. A reflux symptom with very little consequences for the long-term health of these children. What do this study have shown up to now? The REVO trial have shown that there is a difference, a statistically difference, a significant difference between the children who receive antibiotic prophylaxis for 2 years and those who receive placebo. But this is, as I always say, of doubtful clinical value. In effect, you need 16 or 22 patients here of antibiotics to prevent 1 UTI or 1 febrile UTI, respectively. So you need to do 22 years of antibiotic prophylaxis to reduce the number of UTIs of just one of febrile UTI. And the other important aspect of the study is that they have shown that there was no effect of the antibiotic prophylaxis, 600 years of antibiotic prophylaxis for 302 children didn't produce any significant difference as far as renal scarring is concerned. And this data is was confirmed by a meta-analysis of all the published studies, which show that there's no significant effect on more than 1,000 children with reflux in 7 randomized controlled trials on the use of antibiotic prophylaxis as regards the occurrence of scarring. So our guidelines suggest that you don't need to use antibiotic prophylaxis in these children. We say that prophylaxis may be considered in infant and children after the treatment of the acute episode until cystography is performed. In children with reflux grade over 4, so only grade 4 and 5, with concomitant reflux nephropathy, in children with recurrent febrile UTIs, which mean more than 3 febrile UTIs within 12 months. These are all data which regard the disease, the reflux symptom, and there are no data regarding reflux disease. And that's why we have started a trial, which is the PREDICT trial, which is getting to its conclusion, and we'll have the final results in 10 months' time. This is a study who randomized very small children before the 4th month of age with grade 3 to 5 reflux to 2 years of prophylaxis and 2 years of no prophylaxis. We have finalized the randomization. We have randomized 292 patients with more than 800 patients screened. And 70 of these children have been randomized in Turkey. And it's quite interesting, as you can see, there's a very different proportion of males, 77% are males, versus the 92% of the females present in the REBOOT trial. These are very young children. The median age of randomization is 2 months, and very high grade of reflux. 80% of children have grade 4 and 5. The other quite important point is that 52% of these children have DMSA abnormalities, showing already some sort of kidney damage, which is present before randomization and before the first infection, because we randomized children before the UTI. Those are children who arrived to our attention mainly through prenatal ultrasound screening. And these are the 4 classes of antibiotics that we have used for randomization. Mainly is amoxiclavulanate, but we have also nitrofurantoin, trimethoprim sulfamethoxazole, and cefixime. And we left a free choice to choose what antibiotic to use, depending on the country and the local pattern of resistance. If we go to the published guidelines, it's quite interesting to see the differences between medical guidelines and surgical guidelines. Almost all the medical guidelines published suggest not to use antibiotic prophylaxis routinely in children following a first febrile UTI or in children with vesico-urethral reflux, while most of the surgical guidelines suggest to use antibiotic prophylaxis. And that's the same in the studies that we have examined earlier on. I mean, most of the physician studies recommend to not to use prophylaxis, while only a small proportion of the surgeon studies recommend not to use antibiotic prophylaxis in children with reflux. As regards the use of surgery, there have been 4 studies 4 randomized control studies published up to now: the International Reflux Study in Children, the Birmingham study, the London study, and the Swedish Reflux study. All of them showed favorable outcome and no difference in progression of existing scarring or new scarring between the children who were on prophylaxis and those who were treated by surgery. And I'd like to present to you very briefly this study, which was done in, in London by Jean Smelly, who was, because she died very recently, a pediatric nephrologist. And this is an interesting study because it evaluates the long-term renal function in children. They randomized 53 children, 28 assigned to medical treatment and 25 assigned to surgical treatment. And they evaluated kidney function after 10 years in both arms. So it's a long-term study, very interesting. And what comes out from the children who underwent surgery and those who use antibiotic prophylaxis is that after 10 years, there's no difference as regards GFR in both groups. And these are single data from single children. As you can see, there are 2 children in each group who ended up on dialysis, and that's independent by the presence of the execution of surgery or the use of antibiotic prophylaxis. And what do the guidelines say for surgery? Most of the medical guidelines, the NICE and the Australian guidelines do not recommend surgery following the evaluation of the reflux, but while the urological guidelines do recommend to perform surgery. What about this? The published study is the same. Physician studies do not recommend surgery. Surgeon studies mainly recommend to perform surgery in these patients. I'd like to say something very briefly. I have only 4 slides for this regarding this population, because we have spoken mainly of the children within the first 3 years of life. But we have a lot of children who develop UTIs later on. And in these children, following the 3rd year of life, when these children are toilet trained, it's very important to evaluate bladder and bowel function, because we really have to exclude the presence of bladder bowel dysfunction in these children. And there are a number of studies published, and this is a study from the group of Fatosh in Turkey, where there is a clear demonstration of the presence of lower urinary tract dysfunction in children with urinary tract infections after 4 years of age. So that's a very important point. Rather than performing a lot of imaging in these children, it is very important to evaluate how the child goes to the toilet, because in a high proportion of these children, lower urinary tract symptoms are present. And so we have to address these symptoms before addressing the possibility to have a reflux, which would be in any case secondary to the lower urinary tract symptoms. And I thank you for your attention.
Okay. Thank you very much, Giovanni, for the excellent presentation. We get fresh about, again, urinary tract infections and reflux nephropathy. And I'm sure after this excellent lecture, we have some questions to you. And we would like to listen some questions. I will forward them to you. The first question is coming from one of our colleagues from Kayseri, Ismail Dursun, and he's asking, the question is that, what is your recommendation for nitrate positive leukocyte esterase negative patients?
That's a very important question. We believe, and that's what we wrote in our recommendation, is that if you have only nitrite positive dipstick, you are not allowed to make a diagnosis of UTI. That's because you can have asymptomatic bacteriuria. The presence of bacteria can produce nitrites. So infection and inflammation, in most cases, need the presence of leukocytes. Nitrites alone are not the synonymous, do not mean infection in these children. Nitrites alone, in my perspective, in my view, we are not allowed to make a diagnosis of UTI. You need to have leukocytes to make a diagnosis of urinary tract infection.
Okay, thank you. The next question is coming from an anonymous attendee. We don't know the name. And they thank you for your presentation. May I please ask, what is your practice in order to avoid UTI risk in children with congenital solitary kidney with negative MCUG for reflux? And there are some more questions coming, but maybe you can first answer this one.
Right. I will do nothing. He's a normal child. He can do a normal life. But you really don't do any kind of antibiotic prophylaxis or anything else.
Okay.
In my view, if you have a normal kidney, a normal single kidney growing well, you do not need to perform a BCUG in this child. It's a very different point if you have a dilatation of the urinary tract or of the ureter. But if you have a normal kidney with a compensatory growth and no dilation, I wouldn't suggest to perform a BCUG.
Okay, the following question is that, would you do a scintigraphy prophylactically if the child has not presented any UTIs by the age of 1 to 2 years old? And at what point? Thank you for your answers in advance.
No, I wouldn't, really I wouldn't. I mean, if you have some doubts at the ultrasound, if you see an hypercogenicity of the kidney, but if you have a normal kidney, you don't need really to do anything.
Okay. The next question coming from Melipka, and she says, hello, colleagues. Thank you for a wonderful presentation, Dr. Giovanni. What is your opinion about nitrofurantoin in long-term prophylaxis? If you have such experience, thank you.
Well, nitrofurantoin is a very good drug. It has a lower rate of breakthrough infections because the resistance rate is lower, but it has some side effects. It can give some abdominal pain, some nausea. Some children do not accept this drug. And at least in my country, we have difficulties in getting the liquid form of nitrofurantoin. We have tablets. And of course, this is quite difficult to use in small children. So there are pros and cons on the use of nitrofurantoin. If you can use it, it's a very good drug.
Okay, the same colleague also asking if you have been mentioning the MSA scan only, if there is any place for DTPA in diagnostic or febrile UTI?
There is a small place for DTPA or MAC3, and the place is mainly when you have at the BCUG a major dilatation of the pelvis, and you can really have suspicion of the presence also of an obstruction, because sometimes you can have both a refluxing ureter and some sort of obstruction, mainly at the pelvureteric junction. So in this case, but otherwise, there is no indication to perform a MAC3 or a DTPA. A DMSA scan is much better because you can have a precise idea of the renal parenchyma and the presence of scarring.
Okay, another colleague from Ankara, Bora Gülhan, he thanks for this nice overview. What do you think about the future of genetic determinants of UTI recurrence?
I believe that there is a lot of space to study and to do research on this aspect. For example, there has been a study on genetic determinants of the production of uromodulins, and there are some, and this is clearly shown that if you produce more uromodulin, you have less UTIs. But at the moment, we do not have anything precise that we can use on the clinical side. So there's room for studying, but there's no room now for a routine application of this aspect.
Another question from Paulo Calvo. Hello, you don't use trimethoprim alone as a prophylaxis drug?
I don't use, but there are countries where they use trimethoprim alone. It's a possibility. As far as I believe that in Great Britain they are using it, in England, and also in Lithuania, and also some other countries. But that's a possibility, absolutely, yes.
Okay, there's another question from one colleague. A very long, complex name, but the first is Mamea. They said that we have a number of patients with posterior ureter valve who come in with asymptomatic bacteriuria. We usually give prophylactic antibiotics. Should we stop and only give antibiotics when the UTI is symptomatic?
This is a complicated question because I believe there's no precise answer to this question. There are many controversies. I say what is my personal opinion, which is just an opinion, and I believe that there's no space for antibiotic prophylaxis in these children, because if you have a asymptomatic bacteriuria, it will persist, and it's better to treat only the infection. Also because you risk to produce bacteria resistant to antibiotics, and so they could be really worse infections following these resistant bacteria.
Okay, another question from Dalia Ali. What about screening for UTI of siblings?
I don't get exactly the meaning of the question. You don't need to screen because UTI is symptomatic. If you don't have symptoms, you don't have a UTI. In case you would have an asymptomatic bacteriuria, which is not, you don't need to look for. I mean, and if a child is normal, is healthy, and you don't need to do any screening of the presence of an infection.
Okay, another question from Juan David Gonzalez Rodriguez. Thank you for your presentation. What do you think about correction of persistent reflux in a girl?
I would like to have some more details in the story because it's not easy to answer just in this case. I would like to know the degree of reflux. I mean, it's very different if you have a grade 4 or grade 5, or if you have a grade 1 or grade 2 reflux. It's very different if you have a story of infections, a girl who has a lot of infections. I discuss often this aspect with my urologist here in Milano, Gian Antonio Manzoni. He would be more keen in correcting high-grade reflux in girls because of the risk of possible complications during pregnancy. But I've just shown you a very recent study published in Pediatrics in 2020, where a large cohort of women with previous UTIs didn't show any higher risk of developing pregnancy-related complications. So my opinion is surely I wouldn't correct low-grade reflux. I would discuss case by case high-grade reflux in girls.
Okay, the next question is coming from Georgia Malakasiotti. Thank you for the excellent talk. Could you please summarize your diagnostic treatment algorithm for recurrent UTIs in pediatric kidney transplant recipients without an underlying urinary tract abnormality?
Well, if there is a clear definition of without an underlying urinary tract abnormality, it means that some imaging has already been done. I mean, a DCUG and an ultrasound has already been done. I would really try to understand the possible presence of bladder bowel dysfunction, which is very important. And the other point, especially girls and if adolescents, any possibility to have infections related to sexual life, because we know very well that after adolescence for girls, there's a clear relationship between a sexual life and the occurrence of UTIs. So I will really study in a very precise way the presence of bladder bowel dysfunction and possible relation with the sexual life.
Okay, the other question from Hector Rios. Listening to you is always pleasure. Which is your recommendation for performing DMSA gammography? In which patients? Thank you.
You can perform a DMSA both in acute setting and at a late stage. Acute setting is within the first 10 days of the infection, and the late stage is generally 6 months after the infection. In the acute setting, I would recommend to perform a DMSA only when you have really difficulties in making a diagnosis of UTI. There are some situations where you suspect the child has a UTI, there's a lot of fever, recurrence of fevers, and so on. And you have a negative urine culture, but you believe that there is a UTI because you have a positive urine dipstick. So in this case, I would recommend to perform a DMSA scan to see the presence of the acute pyelonephritis. The late DMSA scan is, it was very common to do it many years ago in most patients following a UTI because everybody wanted to know if there were scars. But we know that now that small scars are not so important, so it's not worth to look for the scars. I would recommend to perform the DMSA scan in those children who have a high-grade reflux and a number of abnormalities at the renal ultrasound.
Okay. The next one is from Yin Se from Newcastle. What do you think we need our next big trial on regarding UTI?
What do you think we need our?
We need our next big trial on regarding UTI.
There are a number of very simple questions which are not clearly answered. For example, the number of colony forming units to make a diagnosis of UTI is not so clear. and there's no study who has clearly established what is the number that we use. So this is, for example, a very simple task, but which can really make a big difference. Why in some books or studies it's written that you just need 1,000 colony-forming units from a suprapubic aspirator to make a diagnosis of UTI. It's not clear why only 1,000 and 10,000 for bladder catheterization. So this is a very simple point, but very important because we do not have a precise idea on what we need.
Okay. The next question is from Salih Kavukçu from Izmir. Is it possible transdermal antibiotic prophylaxis for UTI in childhood during the night?
I don't know if I have the answer for this question. I have never used it. I don't believe that it's so different from an oral treatment. So I cannot really answer it in a precise way. I'm sorry.
Okay. The next one from Sami Bahar. Do you recommend prophylaxis with recurrent lower and upper UTI due to voiding disorder without reflux?
I recommend to treat the voiding disorder clearly, and usually if you treat the voiding disorders, you don't need to do antibiotic prophylaxis in these children.
Okay.
In some children, sometimes in some desperate case, I use antibiotic prophylaxis, but generally I don't use antibiotic prophylaxis.
Okay, another question from Mehmet Taşdemir, Istanbul. Thank you for this nice presentation. Would you recommend prophylactic antibiotic for infants without recurrent UTI and with low-grade reflux grade 2, 3? Thank you.
No, absolutely no.
Okay. And the other question from Paula Calho. In the cases of possible benefit with surgery, what kind of technique do you prefer?
I of course discuss it with my urologist because he's doing the surgery. If it is possible, I would prefer the less invasive one. So I would prefer to do the cystoscopy and to inject the bulk agent. This is what I would prefer, but the choice is done by the urologist and not by me.
Okay. Another question from Evgenia Preka. Thank you for the presentation, Dr. Montini. Following the question of our colleague here about with regards to solitary kidney, if you have antenatal mild to moderate dilatation, less than 15 millimeter, that resolves progressively postnatally, would you stop antibiotics when the USS normalizes or not? Voiding stereography negative. We have a disagreement with our colleagues, urologists, about this. They would continue antibiotics, whereas we would stop them.
Right. I would stop it. But my point is that if the BCUG is negative, I wouldn't use antibiotic prophylaxis at all. Even if you have a dilation of 10 millimeter of the renal pelvis and you do not have reflux, there's no reason, I believe, to use antibiotic prophylaxis.
Okay. Another question from Dano Yulich. If we decide to use prophylaxis, how long does it last?
That's a good point. I didn't say that. What I recommend is to do prophylaxis for 1 year in boys and 2 years in females. Why? Because boys have a higher risk during the first 6 to 12 months of life to have infections. Girls have a longer risk. So I would recommend those children with high-grade reflux to do this kind of differentiation.
Okay. Another question from Trama Desponia. Thank you very much. Some surgeons want to treat reflux in order to prevent renal damage from mechanical damage. Could you make a comment?
Right. You can have mechanical damage in reflux, but if the reflux is secondary to a situation, secondary to what? To posterior urethral valve. You have a reflux, high pressure because of the presence of the urethral valve. So this is a very different situation. And here you do not have to treat reflux. You need to treat the posterior urethral valve to remove the valve. Another situation is when you have a detrusor hyperactivity. And so you develop high pressure. And so you have a secondary reflux to the detrusor hyperactivity. But what do you need to treat is the detrusor hyperactivity, because if you do surgery in this child after 6 months, you will have again reflux because you have a high pressure in the bladder. So generally, all the other refluxes are not high pressure reflux. So I do not believe there is a mechanical damage from reflux. And it has clearly been demonstrated.
Okay, now for the last 3 questions, then we will stop. From Jakub, this is the question. What is your approach to focal nephritis, lobar nephronia regarding the antibiotic choice and length of therapy?
The antibiotic choice, I would treat with an IV antibiotic. I use ampicillin sulbactam or cephalosporin, and I would recommend to treat for at least 3 weeks. Of course, not all the 3 weeks IV. You start IV, you follow the patient, you follow the ultrasound and the evolution of the lobar nephronia, which is anyhow a quite rare situation, and then you decide.
Okay, and another question from Saad Yauba from Nigeria. Is it necessary to give antibiotics to all parties with febrile UTI?
If you have a febrile UTI, you need to do antibiotic treatment. Most of the cases, oral antibiotic treatment. In some cases, rarely, you need to do IV treatment.
When do you choose surgery for renal abscess?
Very rarely, very rarely. You must monitor. You need to do a good diagnosis with a CT scan. You treat with antibiotic. I have now admitted in the hospital a child who arrived to us with a renal abscess of 5 centimeters, and this is decreasing very rapidly, very rapidly. No surgery has been done. I, of course, have discussed this child with my urologist, and this is very important to discuss with the urologist, with the pediatric urologist. But generally, it's very rarely necessary to perform surgery in these children.
Okay. Many thanks for this interesting presentation. The question is coming from Adomo Sambo. Is there data about risk of CKD and ECRD in unilateral VUR in comparison to bilateral VUR? And is risk of kidney scarring significant in low-grade VUR?
The risk of kidney scarring in low-grade VUR is absolutely not significant. You can have some kidney scarring. You can have kidney scarring also in children with no reflux, but it's a very rare situation. It's a rare situation.
Okay.
It's not clear to me the difference about risk of CKD and stage renal disease in unilateral. If you have a unilateral VUR in a child with 2 kidneys, the risk is almost 0 because
so another question. Thank you for the excellent presentation coming from Hauda Nasi. In patients with recurrent UTIs, can we trust dipsticks or do we go directly to urine culture?
we need both. We need both. And That's what I always say, because if you go to urine culture, you can have a contamination of the urine, you can have asymptomatic bacteriuria. To make a diagnosis of UTI, you generally need a symptomatic child with the presence of leukocytes in the urine and a positive urine culture. Those are the 3 points. If you go straight to the urine culture, you can miss those children who really have only a contamination of the urine. That's quite important.
Okay. There are some more questions coming, but I would like to thank all the participants. If they have some more questions, they can, I hope that they can ask you by mailing to you and get the answers, because we need to stop this meeting. And I would like to thank again for this excellent lecture, and maybe my colleagues Fatosh and Rezan also will say something, and then we will finish the meeting.
Okay. Fatosh, you go ahead.
Okay.
Yeah.
Giovanni, thank you. I had 2 questions, but I will ask you later. Thank you for your wonderful lecture, and thank you for accepting our invitation.
Thank you to you. It was a pleasure. Thank you, Fatosh. Thank you, August. And thank you, Reza.
Thank you very much. That was wonderful. And we had like 170 participants, which is very good. A lot of them from outside Turkey as well. So thank you very much. I mean, it was a wonderful, very, very fruitful and educational lecture. Thank you very much. Thank you.
Thank you. Thank you.
Okay, bye.
Bye.
Bye. We had more than 200.
Oh, really? I mean,
Yeah.
when I see it, it was 167.
Yeah, okay.
Yeah, when I see it, it was 167. Yeah, okay. All right, thank you. Thank you very much.
Bye-bye. Hope to see you
now.
in our next meetings.
Thank you.
Thank you.
Nice to
Bye.
see you.
Bye.
Thank you. Bye.
Bye.